Thank you, everybody. Thanks for this opportunity. This is actually the third the grand rounds that I've given for the department. Believe it or not, I did one 13 years ago on epidemiology of LUTs and diversity in urology, and then I did one 5 years ago on trauma. So this is on strictures, and if we're lucky, I probably won't give another ever. But now excited to be here. And this is a clinical condition I spent a lot of time treating, and it probably makes up about 25% of the research stuff that we're doing in my group. But this is the first time actually giving this talk. I give a lot of urethral stricture talks, but they tend to be educational based on the guidelines. And so this is one I put together based on some of the research we've done over the years, and hopefully you enjoy it. And I'll keep it moving so that I know urethral stricture is super interesting to me, but to our cancer folks, it's not prostate cancer, so it might not be as interesting, but we'll keep it moving. So these are my disclosures. And just want to acknowledge Dr. Tanago's services were on Monday, and really given all of us an opportunity to reflect on this legend and everything that he contributed to our campus, to our department. 20 years of service as the chair, an incredible track record of innovation and discovery. And I think I have his composite here just for all of the trainees and all of the faculty in the room. He's directly or indirectly impacted our careers a great deal. And really special person, and he's going to be missed. So this talk, it's essentially 3 or 5 sections. First, going to go over some research that we've done, getting the patient perspective on their disease process, and why that's important. Then going to go through some of the issues related to how we define success in urethroplasty and how we surveil urethroplasty patients. Then going to talk a little bit about phenotyping urethral stricture disease and different non-animal models. We're going to go over a few clinical trials, and then at the end, about 10 minutes for the residents on how we think about treating these strictures. And yeah. So this is a study that Lindsay led when she was a resident, actually got a CTSI resident grant to do this work. I've talked about this study before, but it's a conjoint analysis, which is it's a tool created in business to help companies understand consumer preferences. So it's used and employed in medicine to try to understand people's perspectives about the different services we offer. So we looked at stricture, and essentially it's a survey. They get these fixed choices, and so you can kind of understand what their overall preferences are over time. Most people, so this is the whole cohort, and you can see that stricture success rate being the most important thing to people. But interestingly, a lot of interest in how much the copay is, and whether they're going to need future procedures, and less interest in catheter duration, which is maybe a little counterintuitive to me because I feel like that's a question we get a lot. You're able to stratify this by various things that you collect. So demographic factors, we looked at race, we looked at income, we looked at age. On the age thing, we found that older folks had a stronger aversion to when the success rate, if the success rate was low, and if they had to have more future procedures. And we've also done work showing that urethroplasty is safe in octogenarians, as have others. So this kind of data just supports the idea that you really should present the full gamut of reconstructive options obviously taking into consideration someone's overall health before undergoing a procedure. One of the things that we've done is try to find data in places that maybe others aren't looking. This is an example of that, just using message boards. We've done this across a few conditions, but this kind of thing helps inform, hey, what are people interested in that maybe you're not covering in the clinic? What are people interested in that you may be able to answer in your post-op instructions? And this is an example of another case. We call it found data. This is, I don't think Jeff Bezos has incontinence, but maybe he does. But Amazon Reviews doing a thematic analysis and a qualitative analysis of these reviews, trying to understand which product attributes are positive, negative, and what people are saying about them. One of the main ways, though, we get the patient voice is by interviewing them and doing these structured and semi-structured interviews about a disease state. This is around buried penis, which is an orphan condition that some urologists treat, particularly reconstructive urologists. It's not a condition that gets much airtime, and it's not one that's well understood. But you really get a rich kind of interpretation of what the patient goes through in their daily life. This is a pretty laborious process. You have to interview folks until you get content saturation. Then you do this thematic analysis where you're going through and doing this coding. But you get to see the functional and anatomic impacts of the disease. And you kind of get these little vignettes like this person. It's a tough disease to deal with. This is a paper we have under consideration at Journal of Internet Medical Research, where we took those original codes from that paper in JU and ran it through an AI. And you can see, and this is actually work in part led by Kevin, who's one of our fourth-year students. You can see great, pretty good interrelator agreement between the artificial intelligence and the human. And it takes, a fraction of the time. Obviously, this hours and hours and hours of people work, what takes a computer minutes. So there's some issues that we're looking at. We have another paper looking at doing multiple iterations and seeing how the results change. You can see there's not complete fidelity with the human researcher, but this is going to be, I think, a thing for the future that is definitely going to be a big part of this kind of quantitative research. So, a labor of love. This is a project that I've been working on for, embarrassed to say, 10 years, and has taken a lot of my life, but we're just about to submit the paper. So just kind of sticking with it. I know Matt knows that sometimes you just have to stick with stuff. We just got Aqua approved at UCSF. Matt has been working on this for over a decade. So like that, I've been working on this for over a decade. This is a patient-reported outcome measure, disease specific for urethral stricture in the patient's voice. So, we have the IPSS for prostate. This is for urethral stricture. And it's a big process to get the content, to create the questions with interviewing patients. There's a whole science behind it. We have 3 methodologists, 2 at UW, 1 at Northwestern, working on this. And this is an example of why such a tool is needed for our stricture patients. This is the IPSS, and you can just see that it's really not sensitive to anything that we do to the patient in terms of looking at success of surgery. And so we've put this tool together. One of the exercises of putting the tool together was we did these rankings. We had all of these items were created. So we needed to do what's called item prioritization. We had to figure out, hey, which ones should we include, right? It's not all about weak stream. There's a whole constellation of things that happen when you have a stricture. And one of the cool exercises we did was we gave a bunch of patients and a bunch of expert clinicians across the world a list of topics and said, rank them, most important to least important. a little surprising that there was incredible disconcordance. So really the priorities for what the doctors thought was important compared to what the patient thought was important was really skewed. You know, patients are worried about things like, this is the top 5. My stream is split. I have to sit. These kind of things that maybe the physician is a little less keyed into because we're really worried about them going into retention or kidney failure or having pain. So kind of these kind of things just give you a richer picture of the disease process. And this is what the final instrument looks like. It's 13 items, a global satisfaction item, one item that's responsive and given postoperatively, and then urinary and sexual domains. So transitioning into sort of success in urethroplasty, and you know, coming up, you'd go to the meetings and you'd have this phenomena where everyone present their data and everybody's success rate is like 100%. And you'd be like, damn, because you'd go and do the case and, you know, it wouldn't be 100%. Why is that? That's crazy. You know, this other thing about how do we surveil these patients? How do we kind of keep track of whether they're doing well or not doing well? None of that stuff has really been well defined. And this is a seminal paper from Germany, and it's fascinating. I've highlighted 2 data points that I want you to pay attention to. One is on that right side where it says success. So the pipe is open, the guy can pee, but 7% of the time they're really dissatisfied. They're not happy. They're pissed off. And then on the flip side, they've been scoped and there's stricture recurrence. You know, it's not completely occluded, but there's a stricture recurrence. And you know, 80% of these people that have a stricture recurrence are actually quite pleased with their surgery and their surgeon. This maybe the surgeon is like super charismatic or caring or empathetic, but like there's something there on both sides of that that's very, very interesting, and it speaks to all types of surgeries, to be honest with you. You know, so these 2 questions about success and some of these things that lead to dissatisfaction helped motivate a group of reconstructive surgeons from across the country who have really, really, really deep ties to UCSF and to Dr. Makinich to study these conditions and to study reconstructive conditions, but to try to answer these questions. So including myself, we have 3 former residents in this group. Everybody was either a fellow here or a sort of a grandchild of a grandfellow of Dr. Makinich's, except for Drew Peterson, who's at Duke and the lone wolf. But I'm past president of this group. This group's been together for about 13 years and has done a lot of work. Here we are in Iowa City with Brad Erickson, who I'm going to talk a lot about as we show research. He hosted us at his institution. We get together a couple times a year. So this is, you know, what predicts for dissatisfaction when the urethra is still cystoscopically normal. Anytime somebody has any sexual issues, that can be a gamut of, you know, like their glands doesn't engorge as much. They have core D. Maybe they feel like their erections aren't as firm as it used to be. Any kind of pain, obviously, anything associated with the stricture coming back, ejaculatory issues. These are all associated with dissatisfaction after your surgery. And you know, these folks that have 100% success, you know, there's a formula to get there, and it's called don't follow up your patients and don't know what happens. But we looked at a cohort of our patients and stratified them by various ways that we could define a recurrence, whether that's by questionnaire, whether that's by uroflow, whether that's by retreatment, which tends to be the least sensitive. So you want the highest success rates, just define it by, they came back to me and had a DVIU. And you can kind of see that there's just varying degrees on how we define these things will lead to how successful you are. We looked at how much surveillance costs, and that part of the data was interesting, but the real thing that I thought was interesting was all these different lines are different surveillance strategies. So there's no gold standard. There's no sort of way that that no one has defined how this is done. I think one of the most common and popular ones, and the quote unquote gold standard, is probably cystoscopy, because that's you can physically tell if the stricture is recurred or not. And so we've studied the impact of this, and how, do we need to do this? Is there any value in doing it, because it is invasive? And what we've found, and this is the short-term data, that if you have a scar recurrence on your 3-month cystoscopy that's under 17 French or below this, you can't pass the scope. You have a pretty high likelihood of needing a future intervention. So, and this is the same data, but long term. And so you can kind of see these lines really. So a lot of guys will have some degree of scarification at the site, some degree of narrowing, but it causes no symptoms. They have no problems. And it seems if you're able to pass the scope, that's going to be considered a success, and you don't need to really surveil them anymore. And they can kind of just report back to you if they develop symptoms. Because the reality is, actually, after urethroplasty, people can develop recurrence throughout their whole lifetime. We've seen people have recurrence from urethroplasties 30, 40 years, 50 years earlier. But if they have a stenosis less than the size of the scope, it's probably a good idea to surveil them a little more tightly. So bring them in for uroflows, PVRs, just to get a sense for what's going on, because they're likely to have a real recurrence and need some therapy. So one of the other segueing things that we've been interested in is phenotyping the disease process and looking deeply at and describing it so that we can study it better. And one of the things that we really lacked in urethral stricture disease was a comprehensive classification and staging scheme. And so Brad Erickson, who's like my BFF in urology, and he was a year before me in fellowship, so I had to take all of his calls since he was super lazy. No, I'm kidding. I'm not still bitter about that. That's a joke, running joke between me and him. But he really pioneered this staging and validation, or the staging and classification scheme that takes into consideration length, it takes into consideration location, it takes into consideration etiology. Might remind you of something, cancer people. But this is, previously it'd be like, oh yeah, it was a bulbar stricture, or oh yeah, it was a penile stricture. But this kind of, for research purposes and, being able to compare apples to apples for different therapies we might do has been really important. We've done the same thing for ureter and also for buried penis. And it's responsive, the staging system is responsive to high-risk strictures being more likely to have recurrence and other issues, as you'd expect. But the group has done a lot of work trying to understand the impacts of urethroplasty on the various phenotypes that we see. One of the things we often see is urgency. This is work that Lindsay did, Dr. Hampson did as a fellow in the Terns group, and just showing that the urethroplasty really helps urgency over time. One of the great joys of my academic career so far has been able to have a fellowship that Jack gifted me, and getting to work with really smart people. Here, and we're waiting on you to catch up, but it's okay. I'm kidding. Huron's great. We love Huron. This is work done by Andy Cohen, who is our fellow, and he's at Hopkins, and Herman Patino, who is a Colombian reconstructive urologist. And this is kind of this idea, can we get a non-animal model for urethral stricture disease? And so this was a really fun project. Anytime you can go to Home Depot or use the 3D printer, you're like, life is good. But essentially, the hypothesis and what we were most interested in was spraying. As you saw, patients are very interested in spraying. It's a big concern of theirs and a big bother. And this stuff is actually what the janitors use to sweep the floors. And this is methylene blue. And it would take pictures of this, and then it'd get transcribed and quantified. And then we would do surgeries on cadaveric penises to change morphology and experiment with different flow patterns, high, low, and then created these 3D printed constructs that mimicked a urethra. So not perfect, because it was kind of hard plastic, but certainly the experiments I think gave us some insight into what our surgeries will do to folks. This is just a little video of how the thing works. So, and believe it or not, that's the flow that some people have, which is really wild. But so we'd get these maps, and we'd be able to kind of discern, there'd be areas, there'd be locations, and able to just learn things about how these different morphologies impact flow. We also did computational fluid dynamics to help us understand what's going on hydrostatically in the urethra. And interestingly, as you'd expect, the higher the degree of stenosis, the more voricity or kind of chaotic flow. And there's a big interest in our group around squamous metaplasia and what's transforming in that process. There's likely some type of like cracking of the tissue, micro tears that lead to extravasation, and different response of the tissue to that trauma. We also did some computational fluid dynamic modeling, looking at different scenarios that we see with asynchronous strictures and various things, and trying to understand what the impacts of that is. Brad led this study where we again did deep phenotyping. This one, I think the cancer folks, you guys do this on the daily basis, but none of this stuff honestly has ever been done in recon, which is kind of cool because the bar was so low, someone like me could really make a contribution. But Brad and a site at Utah and at Minnesota and Leahy, we produced this study, phenotyped folks, got tissue and serum, and then did a follow-up protocol. And essentially what we found, 3 groups looking at those that were traumatic or iatrogenic versus idiopathic versus inflammatory. And the interesting thing in stricture disease, we know so little about the pathophysiology. 60% of the strictures are idiopathic. Often we'll kind of chalk it up like, did you play sports? Did you get hit? But most of the time we really don't know where a lot of these strictures came from. And the thing that we found in this study was that there's actually a much higher concordance of these idiopathic strictures with inflammatory strictures than with trauma strictures. And so the degree of inflammation, and the other interesting thing was we sampled the stricture in normal tissue before and after. And often there was quite a bit of inflammation across the urethra away from where the stricture was, both upstream and downstream. And then a bunch of different cytokines that are associated with inflammation. So this is ongoing work, and we're doing some genetic analyses of these, and hopefully this bears some good fruit. One of the conditions I'm very interested in is lichen sclerosis. This is some population-based data looking at lichen sclerosis, and just knowing that there's an association with different autoimmune diseases and lichen sclerosis. So it's certainly got to be immune mediated in patients. The other thing that's interesting, this is military data, and then this is national population-based data Sarah Blaschko wrote up, but there are these kind of consistent corridors where you're seeing more patients, a higher density of patients with lichen sclerosus. I don't know what it is about the Northwest that leads to more men having lichen sclerosus, but there's something about the environment up there that is contributing. There's a lot of theories as to what's going on there. People have written again about the immune components of lichen sclerosus. People have also posited that there's a infectious component, and we have one of our other students who's a microbiome PhD can opine on this next study, but we have also looked at the microbiome of our lichen sclerosus patients, and as you'd expect, compared to other stricture patients, they have incredible diversity of the bacteria in their urethra. And, you know, we've kind of thought, what could this be all caused from? And this is sort of a thing that we published in JU just on the potential etiology of this two-hit hypothesis, that you have some insult in that, but there's, for you to really develop the disease, there's some underlying predisposition. Typically, this is a disease process, which, if you've treated these folks, it can be profoundly impactful on their lives, both sexually and for urination. Most of the time, though, it's very responsive to therapies, particularly high potency steroids, doing a circumcision, and guys do fine. But still don't really know why this disease forms, and it's not curable. They'll have it for their lifetime and need to treat it for their lifetime, even if it doesn't progress. And, you know, we've changed how we treat these folks. This is data from Duke, where they suggested doing a minimally invasive approach. You know, a lot of times we just take the whole urethra out and do a staged urethroplasty. So put a buckle down and come back 6 months later and turn it into a tube. We've gotten to dilating these folks more and using intraluminal steroids. But there's actually a bunch of different things that are being used to treat lichen sclerosus, including laser, including topical and systemic tacrolimus for the most severe cases. But typically, high potency steroids do the trick. There's likely a genetic component to urethral stricture, and others have done work on this. We're doing work with our tissues now. A big focus of mine has been radiation and all of the things that it can do to the urinary tract. This is a guy with localized disease treated with radiation, developed lymphedema that was so bad he had to actually have a colostomy from it. But I think the impacts of radiation therapy are underappreciated. And one of the big areas that it impacts is the urethra, particularly the membranous urethra. I think everyone who's scoped a patient, particularly our cancer colleagues, is familiar with this white tissue. It's essentially, it's like an eraser, and there's no blood supply when you cut into it. We know that when more radiation is given, you're more likely to have a urethral stricture disease. This is pooled data. And we also know that the rates are much higher than what this systematic review and meta-analysis shows, because you can get these strictures 20 years after the fact. And so this is, I think, an underappreciated problem that in general is, I've gotten away a little bit, again, similar to lichen sclerosus, from really aggressive treatment, particularly in older folks. Younger people will be a little more aggressive. But a urethroplasty can definitely be successful in these folks. The success rates are a little bit lower than what they would be in someone that's from other cause. And you can see that they most commonly occur in the membranous urethra, but they can occur all throughout the whole thing. So I had a mentor, a research mentor. She was in medicine, actually, and one of her mentors told her this story about, you know, at some point you need to stop bringing home just bringing home dead fishes, because If all your research is, I studied X and X is associated with Y, then you're never going to really move the field forward. You actually need to do something. So the sort of the Michael Jordan of data is probably going to be the clinical trials. So here's some clinical trials that we were involved in. This is, I think, a really important question. This is a former fellow of Jack's, Jeremy Myers, who's the chief at Utah. This was a trial, about 40 sites to accrue, but it's looking at whether you need to do endoscopic realignment when you have a pelvic fracture urethral disruption. A lot of controversy there because there's this idea, if you do an alignment, there's a percentage of those folks that won't need a urethroplasty because you got them set up. There's also this idea that the stricture is going to be, it's going to be easier to find the other end when you do the urethroplasty if they need one. On the flip side, some people say, no, actually, I've found that these strictures are harder to treat, and there's more ED and there's more incontinence because there's all this fluid extravasating when you do these procedures. So he randomized by site, each site would do a different technique. So whether endoscopic realignment or suprapubic tube. And the punchline is there's no difference. So the right answer is to put a suprapubic tube in. This is they're working on the next iteration of the Urotrauma guidelines. This is going to be in it. So at the general, if you ever have one of these, you don't need to, you can attempt, but you don't need to struggle with doing endoscopic realignment. Just just drain the bladder. We're the clinical site for this $4 million phase 1 study where we're taking a biopsy of the bladder, and the tissue then goes to Wake Forest and Tony Atala's group, where they grow out a sheet of urothelium that we then implant for urethroplasty. This was kind of conceived in 2015, and interestingly, and I'll go over this, how we treat these now has changed. And so I think, accruing this study might actually be more challenging than it was originally envisioned, because a lot of these very posterior strictures, we don't actually use a graft anymore. We can do a non-transecting technique very effectively. And that's kind of changed how we treat these. I'll talk a little more about that. A big kind of change in urethral stricture treatment is the Optilume balloon. This is a paclitaxel covered balloon. So just like the Nephromax balloon that you use to dilate something, this is just like that, except it has medicine on it. And it really does seem to work. This is 1 year data. The 3 and 4 year data look like about 60% respond to this therapy. So if you have a urethroplasty that's 85% successful, but an endoscopic thing that's 60, I think this is really going to kind of change some of how we do things. I offer this when we have a stricture recurrence after urethroplasty. If someone's morbidly obese and I'm really trying to avoid a urethroplasty, I would employ this. But it'll be interesting to see how this, in other things where urethroplasties tend to be less successful, like radiation strictures. So there's a lot of research being done looking at these balloons. There's also, this is going to be a growth area. Paclitaxel was just sort of a off-patent drug that had been used in the 60s for cardiac stents. There's going to be a lot of different medicines that are going to be employed on balloons to treat urethral and ureteral strictures. And as you know, Optilume is being used for BPH as well. So it's a growth area. It's going to be interesting. So I don't see anyone asleep yet, which I'm proud of. So this is the blood and guts part for the residents. We're going to look at how we treat these things, and it has to do with where it is, how long it is, what the etiology is, what's the milieu of the patient. This was a paper I wrote as a resident under Jack's mentorship. And essentially, we just did a multivariate analysis of long-term urethroplasty outcomes. And the punchline is that the simpler the urethroplasty, the more likely it's to succeed. And I use that as sort of a guide. In general, we'll offer and prioritize the easier approach for the patient, and that just tends to work better. You know, pretty much everything Jack taught me is gospel, and I still do, but techniques have evolved and changed. And this is one that we do quite a bit now. It's called a non-transecting urethroplasty. You know, previously we would cut this bit out and then connect these two directly. But now we're able to basically start here, cut through here, mobilize things, and then fold it over, and it works beautifully. So this is what that looks like. This is the GU diaphragm. This is the kind of the membranous urethra. We'll kind of sweep these muscles off. You'll often get these post-TURP strictures where you're right by the membranous urethra, and it's important to be able to sweep these muscle fibers up, and you'll preserve continence. But for this technique, it's a Heineke Michelitz. That's plain and simple. So you make a longitudinal incision. You have an option to remove scar tissue here. We actually choose not to, as long as the lumen is fine. We'll leave this in place. And you can, depending on where you extend this incision to, this will move this and orient this in a way where there's no obstruction. So this cartoon shows removing some of that scar tissue. We haven't found that to be necessary. These patients do incredibly well. This is a 90-minute surgery, and success rates are the same as anastomotic. So it's technically easier, much less blood loss, less risk of sexual issues. And so it's across the globe been a popular technique. But, this is a guy who had a straddle injury. So the straddled a fence or some type of deal where the urethra gets crushed against the bone here. And what results is, actually it's the inferior pubic rami that usually gets crushed against. What results here is a very dense wheal of scar. And so something like this wouldn't be amenable to a non-transecting. So this is the kind of the tried and true EPA or end-to-end anastomotic urethroplasty, where the diseased tissue is marked, excised, you spatulate on either end, and then do a single layer back wall, bring the mucosa together, bring the serosa together on the ventral surface so that that spongy tissue can recannulate. A technique we do a lot, buccal urethroplasty, so graft urethroplasty. It can be put any which way. And there's a lot of, we're still kind of arguing, I don't know, we're still arguing the same things back and forth, whether ventral or dorsal. I prefer dorsal. I feel it has better backing for the graft, and you won't get sacculations or other issues if you have a stricture recurrence. But we will use ventral if it's a very obese patient and a very proximal stricture, so it's very deep down there. We'll prefer to use a ventral buccal. But this is the cartoon just showing you how these things look. When the plate is poor and the stricture is long, we'll cut out a segment. We'll do what's called an augmented roof. So this is kind of what that looks like in action. You put the buccal down, you cut a segment out, and then you have this little patch there that helps everything reach. You don't need to close the mouth, but we used to close the front part of the mouth. I kept this guy admitted for 100 days and took pictures every day of his mouth. No, I'm kidding. But we closed the front end of the mouth and left the back open for bleeding. Now we just leave the whole thing open, and it heals quite well. But look at like day 16. I mean, so this guy just said, I'm going to take pictures of my mouth every day for 100 days. I'm serious. I was like, oh, cool. We'll write it up. But it's pretty amazing. The mouth is a pretty amazing organ, and it heals nicely. Patients tolerate the dissection well. And so it's a graft that's used to an aqueous, dirty environment. It transplants really, really well, and it's the preferred graft. But there are many ways to do this. So, in my practice now, we would do dorsal onlay for something like this penile stricture, which is, this is a pretty tough stricture to treat. But this is the Makinich flap. This is a fasciocutaneous flap, very elegant surgery. And in Jack's hands, he'd make it look so beautiful. This is basically there's an island and a pedicle, and you really can reach way far back there. Honestly, getting all the way to the apex of the prostate. And we don't do this as much with the buccal grafts, but it's still a valuable surgery to know about and have in your armamentarium. This is just to show that you don't always need to do the heroic urethroplasty. And sometimes the perineal urethrostomy is going to be the right approach. And these tend to be technically very straightforward. We use an Orandi flap, this inverted U. These are, 80-minute surgeries. They go well. You basically mature the skin to the urethra, and the person sits to pee. We looked at this comparison of, so let's take this person and offer him two things. Complicated urethroplasty. So you have to harvest both sides of the mouth. You probably need to take a wide graft, split it down the middle, and stack these grafts. So maybe 3 or 4 stacked to get this, to reach this distance. Or you could do a fasciocutaneous flap. On the other hand, he could have a perineal urethrostomy. But one thing you can definitely tell him is that you're going to have more stricture recurrence with the complicated urethroplasty. There's just more points in the whole repair where there's going to be a potential problem. And the interesting thing is that your urinary and your sexual outcomes are going to be similar between the PU and the complicated urethroplasty where you pee at the tip, which is not intuitive because obviously when you ejaculate and you have a PU, it's coming out the bottom. That you would think may be bothersome, but usually by the time the person gets the PU and they're a candidate for the PU, they're really sort of over all of the medical stuff related to their peeing, and they just want the thing that fixes them, and they don't want any more surgeries. Going to talk a little bit about bladder neck reconstruction and bladder neck contracture. I trained learning using mitomycin. Not a huge fan of it. I don't know I don't know if it works that well, but typically when someone presents with this, we'll do a gentle dilation with a balloon, and that fixes things, and they don't need anything else. Sometimes it becomes recalcitrant, and then you have a decision point. If they're leaking, I'll go ahead and do something endoscopic where at the 3 and the 9 o'clock position, we cut to fat. And that works probably 80–90% of the time. They'll be floridly incontinent, and you'll need to put in a sphincter. But if they're already incontinent to start, that's a pretty simple surgery, and they tend to do well. If they are dry but have these recurrent strictures, then we'll do some type of robotic bladder neck. And when I say we, I'm usually like the cheerleader in the room, or Dr. Meng and Dr. Wynn are doing the surgeries. So this was like an initial experience, and it's never a good sign when there are more authors than patients in the paper, but here it is. So this is this classic YV plasty. It technically very straightforward. Sometimes in the radiated cases, that base of the Y goes back pretty far and it can be a little uncomfortable, but in general, these patients do incredibly well. This is a little more mature data that we got in European, and just shows that there's a lot of different things to think about, whether the lumen is present or not, how extensive the fibrosis is, whether you would do an anterior bladder flap, whether you would redo the anastomosis, whether you need to do any of these other adjuncts like add in a perineal dissection if there's membranous involvement. So wrapping up, basically today we talked a little bit about understanding the patient perspective, and a lot of times it's not exactly what we would think. So I think that's really important area of research. We think we know it, but I think our patients, there's a lot we can learn from them. Understanding how we surveil patients is going to really help determine a lot of things, including how successful we can report our surgeries are. We've done a lot of work on phenotyping these surgeries and trying to understand the gamut of how they present, and working on some clinical trials. I just say for the trainees and the junior faculty in the room, the research is core to who we are in the department. Research is a foundational mission of ours, and I wouldn't have been able to do this stuff and all the other stuff I do had it not been for UCSF, had it not been for, incredible mentors, incredible peer mentors, co-residents, trainees. And, I just encourage you to take advantage of the opportunities that you have here, because it's a really special place that we have, and we're all incredibly blessed and lucky to be here and to get a chance to work with each other and work on important problems. I've certainly benefited from so many incredible trainees, so many incredible mentors, and of course, my wife. I want to thank her, because when I was a chief resident, where are the chiefs? Do we have chiefs in the room? All right, check this out. Don't do this. When I was a chief resident, wasn't yet engaged. I was going to get engaged in like a month, but I forgot to thank my now wife. And so every awards show or anytime someone gets up there and thanks their spouse, she punches me, just like, so I never pass up an opportunity to thank her for being incredibly supportive, and thank all of you all. So thank you.